Hey everybody, it's Chris Morosky, and in this video we are going to go over presentations and note writing in OBGYN. Lots to cover here. This is lengthy, but this is going to be super helpful to you as you start off your OBGYN clerkship. So let's get after it. What I always like to tell students is that there are two halves to every OBGYN's brain. There is an OB brain and a GYN brain. And it's really important that when you're doing your presentations that I am using the right half of my brain. For example, if a patient presents to the emergency room with vaginal bleeding and pelvic pain or cramping, if I'm using my OB brain, I'm going to be thinking about miscarriage, ectopic pregnancy, if it's in the first trimester, and then in the third trimester, I'm going to start thinking about labor, placenta previa, placental abruption. Now, if you take all of that and switch it over to my GYN brain, I'm going to start thinking about all the causes of abnormal uterine bleeding. So, fibroids, polyps, coagulopathy, ovulatory dysfunction, just to name a few of those things. And so when you're doing your presentations, it's really important that you tell us exactly what's going on with that patient, meaning is she pregnant or not pregnant. And you'd think it'd be as easy as just saying that, but it's not, because there's a lot more information inside your presentation that I need to know besides just is she pregnant or not. So what I'm going to do is I am going to teach you first how to present a pregnant patient and use what we call the OB One Liner. So a lot of the times I'll ask, give me the OB One Liner. Just give me a one liner on that patient. And if she's pregnant, this is what we're going to want to hear. Okay, so let's see what that looks like. Here is the beginning of the OB One Liner. The patient is a 26-year-old G blank P blank 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 blank. And yeah, if you're looking at this right here, you can see what I'm getting at is we've got to go over G's and P's in pregnancy. So let's start with that. All right. Now, G can mean either gravid or gravida. And the way I like to think about this is that this is a pregnancy occurrence. Okay? A pregnancy occurrence. Very importantly, women can only be pregnant one pregnancy at a time. And a pregnancy has a beginning and a pregnancy has an end. What happens inside there can get very confusing, especially if it's a multiple gestation. But just know that if a woman is pregnant with a singleton or she's pregnant with triplets, that is only one pregnancy occurrence. And when we start talking about the end of pregnancy occurrences, that's where we get into parity. So let's take a look at that. P stands for parity or para, and that is the end of the pregnancy occurrence. That's why you don't want to think about parity as how many babies does she have or how many kids does she have, because not every pregnancy ends with live-born babies. Some do, some don't. And so that's why think about G as a pregnancy occurrence and think about P as an end of the pregnancy occurrence. Okay, and as you saw before, the parity gets broken down into 4 different things. So we'll take a look at that right now. So here are the 4 things on the bottom here of how parity gets broken down. It's T, P, A, L. Has nothing to do with syphilis, the spirochete, but that's treponema pallidum. That's the way that I always initially remember this until it became like part of my job. But T, P, A, L. So T stands for a term delivery. This usually results in the birth of a healthy, live-born child, but not always. But if a pregnancy goes to 37 weeks and 0 days or beyond, that is a T, and that is where you would put 1 for the end of that pregnancy occurrence. Preterm has a range that not everybody's always sure about, but preterm starts appropriately at 36 weeks and 6 days and goes all the way down to 20 weeks and 0 days. And the reason that I think 20 weeks and 0 days was selected is despite all the technology that's out there, there probably won't be enough fetal development to result in a live-born baby prior to 20 weeks, even as we go into the future. When I was a resident, it was 24 weeks. Now we're talking about 23 weeks, and there's even conversations about resuscitating late 22 weeks. It'll be some time before we get down to 20 weeks, I'm sure. So anything in that range, any pregnancy occurrence that ends in that range is P for preterm. Now, A stands for abortion. In OBGYN, abortion does not necessarily mean pregnancy termination. Now, certainly it includes pregnancy termination, but it doesn't have to mean pregnancy termination. It can also mean miscarriage. It also can mean ectopic pregnancies, molar pregnancies. Basically, it's any pregnancy that ends at or less than 19 weeks and 6 days. Okay? And just based on viability, that will not result in a live-born baby. Okay? So that is abortion, not to be confused again with pregnancy termination. L stands for living children. This usually can be simple if there's term deliveries and all the babies are healthy and now growing up and are alive. But it's important to keep in mind that in multiple gestations, you may have 2 extra living children for a twin pregnancy, 3 for triplets. But sometimes one of those babies won't survive, and so the living won't always add up. Also here, you have to keep in mind that childhood, death, or loss, or even adult, depending on how old the patient is, may also cause the living children to not match the T's and the P's when you start adding them all up. So we'll do a little bit of practice to go over that so that everybody can kind of get familiar with it. But before we do that, I want to just go over multiple gestations. And what's really important to understand, again, it's a pregnancy occurrence. And so the end of the pregnancy occurrence, your parity, does not have to do with each fetus. It has to do with how far that single pregnancy goes. So, for example, if you have a G1P0, a woman who's pregnant for the first time with a twin pregnancy, and she loses a twin, one of those twins, to miscarriage at 18 weeks, but she then goes on to deliver that one live baby at 39 weeks, she would eventually, once she's delivered, be a G1P1 because she had that term baby at 39 weeks, 001. She would not be a G1P1011. Again, not to feel bad about that lost fetus, but we're just talking about a pregnancy occurrence and end of pregnancy occurrence. If multiple gestation babies are lost along the way, they don't go down as their own separate para. Okay? Hopefully that's very clear. It gets to be a little confusing. Okay, so here's some practice. If you've got a patient who's a G3P1011, what would her pregnancy history look like? And is she pregnant right now, or is she not pregnant? And the answer is yes, she is pregnant. So she's had 3 total pregnancies, including the pregnancy that she has right now. She has that 1-term pregnancy. She has no preterm pregnancies. She has 1 abortion. Again, that could be a termination, an ectopic, a miscarriage. And she has 1 living child. So if you add that up, really she has 2 prior pregnancies. 1-term pregnancy with a living child, 1 abortion. And so since she's a G3, that means right now she has to be pregnant. Okay? Hopefully that makes sense. Let's do another practice here. A G5P2032. Is she pregnant or not pregnant? And what is her pregnancy history? And the answer is this patient is not pregnant. So she's had 5 total pregnancies. 2-term pregnancies, of which she has 2 living children, and then 3 abortions. So if you add up the 2-term pregnancies and the 3 abortions, that would be 5 pregnancies. Since she's a G5, that means she is not pregnant right now. All right, let's flip this around, and I'm going to give you the history, and then you come up with the G's and P's. So, a patient who is currently pregnant. She had a twin pregnancy where 1 embryo was lost at 8 weeks, and then she went on to have a 32 weeks preterm birth of a baby who is currently alive. And she has another singleton pregnancy in the past who went to 38 weeks, and that child is alive. All right, so let's think about that. She's pregnant. These are her pregnancy histories. What are her G's and P's? The answer She's a G3P1102. And again, don't let that 8-week loss in her twin pregnancy make you think you want to put a 1 in her abortions. That would cause her to have 3 prior pregnancies, and that's incorrect. She has 2 prior pregnancies, one that went to 32 weeks. Yes, along the way, a twin was lost at 8 weeks, but she has that 1 preterm birth in a live child. She has that 38-week singleton birth that results in a live child. So there's her 2 and her para. She is pregnant, so that would make her a G3. G3P1102. All right. Here's another practice one. She is not pregnant. This patient is not pregnant, and she had 1 triplet pregnancy where she delivered all 3 babies at 28 weeks. 1 of those babies lived, 2 of them died. What would be her G's and P's? And yes, this patient would in fact be a G1P0101. She's only been pregnant once. She's not anymore. And so that pregnancy ended. And that pregnancy ended at 28 weeks. Now granted, it was triplets, and 2 of those babies were also born, but they're now dead. So she would only have 1 living child. And this is important to point this out, because this would also look like a patient who had a singleton pregnancy that delivered preterm with 1 live baby. In this setting, you would have to give a little bit more history to let us know that she had a previous triplet pregnancy and lost 2 of those babies. Okay, so this is all super crazy and confusing, and a lot of the time I get asked, why do this? Well, it's really important to know that in OBGYN, a history of anything in pregnancy is the biggest risk factor for anything in pregnancy. So a history of twins is the biggest risk factor for twins. History of preeclampsia, biggest risk factor for preeclampsia. You name it. Gestational diabetes, preterm birth, going to term birth, breech presentation, anything. The history of itself is the biggest risk factor for it in the future pregnancy. If you ever get pimped on something, always raise your hand first, to name that risk factor. And so with that, you can see on the bottom here are 2 different pregnant women. The first one is a G5P4004. This is a woman who's had 4 prior preterm births and has 4 living children. She's really great at being pregnant. This is somebody that the 3rd-year clerkship student could take care of with barely any supervision. This lady knows what she's doing. She's going to do fine. Compare that to a G5P0221. This patient has a lot of complications in pregnancy. She has 2 abortions, so losses right off the bat, but she also has these 2 preterm births, of which she only has 1 living child. So it's probably very early preterm complications. And so this patient is complicated, and I know that just by her G's and P's. This is somebody who's going to need me to pay attention and be supervising you the whole entire time for her visit, right? Because she's complicated. All right, and last but not least, winging it. Winging it means you're not prepared. So if you go in and talk to a patient, you take her whole history, and you pop out the room, and the resident comes right up to you and says, okay, give me a presentation. You can do G's and P's off the top of your head if she's a G1P0, meaning this is her first pregnancy ever, or if she's a G2P1001, meaning she's had 1 previous term birth, that baby's alive, and this is her 2nd pregnancy. Other than that, what I recommend you do is calculate this stuff. Tell the resident, please give me 1 second to calculate her G's and P's. We can always hear when your G's and P's are off. It confuses us. We actually stop listening to your presentation, and we're trying to calculate the G's and P's in our mind. So if it's more than 3 pregnancies, just take a moment to calculate it before you do your presentation, okay? All right, so we've made our way through some of the OB one-liner. Let's take on the next part here. So the patient is a 26-year-old G3P1011 at blank weeks and blank days with an EDD of blank by. Okay, there's a lot to unpack there, but not only do I need to know if the patient is pregnant, but I need to know how far along in the pregnancy she is. I need to know if she's 1st trimester, 2nd trimester, 3rd trimester. And I specifically want to hear it in weeks and days. And then I want to know what her due date is in relationship to how you came up with telling me how many weeks and days she is. So what's really important to cover here is how do we date a pregnancy, right? Okay, so pregnancy dating is done by 2 things. It's done by the last menstrual period, and it's done through pregnancy ultrasound. Almost all of our patients are going to have had a pregnancy ultrasound that will either confirm the last menstrual period or it will be different than the last menstrual period, and we're going to use the ultrasound more reliably than the last menstrual period. But let's first talk about the last menstrual period. When we're talking about the last menstrual period, we are talking about the first day of the last menstrual period. We're not talking about the heaviest day. We're not talking about the day it goes from spotting to real bleeding. We're not talking about the last day. I always say it's the first day that anything comes out of the vagina that is on the electromagnetic spectrum of red. So pink, red, brown. It can be spotting. It doesn't have to be much of anything. That eventually turns into the period. That first day is the first day of the LMP, and that is the LMP you should use for pregnancy dating. What you could do is the old-fashioned Nagel's rule, where you add 3 months, subtract a week, and add a year. But basically, all this gets done in an app nowadays. You should download an app. ACOG has an app. There are many different apps within your med calculators. But we are going to expect that you guys can take an LMP, put it into your app, and give us a due date. So that's a requirement of the rotation. You're going to get hit up on that right away in the clinic. What you also want to do in terms of last menstrual periods is provide an adjective. You want to let us know if it is a sure LMP, and that is usually a woman who is using a calendar or an app on her phone to track her period. Those patients are usually very accurate. The next one down would be an unsure LMP, and that's a patient who is either not really tracking her period and they're regular, but she just isn't sure, or it's a patient who's got an irregular period, and so even with the amount of tracking, it's hard to know like when exactly was her last menstrual period. So that is an unsure. Then the last one is an unknown last menstrual period, and this is for patients who are maybe recently postpartum or breastfeeding, or have really bad PCOS or other causes of anovulation, and they have a very, very irregular period. You would want to present that as an unknown LMP when presenting your one-liner. Okay, so sure LMP, more reliable than unsure LMP, more reliable than an unknown LMP. All right, and then getting into ultrasounds, basically, people are going to grow to be different sized babies as they're born. Some babies are born 11 pounds. Other babies like me were born at 5 pounds. So as we go through the pregnancy, we reach whatever weight we're going to be. But interestingly, in the first trimester, especially like 8 weeks and less, every single baby is exactly the same size with very little wiggle room. So a first trimester ultrasound is way more accurate with less wiggle room to either agree with or change the due date from the LMP as opposed to the second and then third trimester, which is the least accurate. So if you do an ultrasound in the first trimester and it is 7 days or more different, either ahead or behind of the LMP, you would change her due date based on the ultrasound. If it's 6 days or less, you would say that the ultrasound confirms the due date by her LMP. And then you can see in the second trimester, it's got a wiggle room of 14 days, and then third trimester, 21 days. So basically, it's 1 week, 2 weeks, 3 weeks. Kind of easy to remember. And an example of this would be that if you have a patient whose estimated delivery date is December 15th, 2020, based on her last menstrual period, but her 7-week ultrasound says that her due date is December 23rd, 2020, because that's more than 7 days, you would then change her due date to 12/23/2020 by her ultrasound, not her last menstrual period. Okay, so that's how we use both the last menstrual period and an ultrasound to date a pregnancy. And so similarly in your app, you would want to be familiar with the section where you can type in how many weeks and days she is by her ultrasound, and then the date, and then see what the estimated delivery date is from that. All these apps will do that for you. Okay, so that's pregnancy dating. And with all that, you can get to this real fancy OB one-liner right here. The patient is a 26-year-old G3 P1011 at 14 weeks and 5 days with an estimated delivery date of June 16, 2021 by a last menstrual period of 10/4/2020, consistent with an 8 weeks ultrasound, who presents with blah, blah, blah. And then you're going to get into the HPI right there. But that is the one-liner right there. And you're going to want to do this every single time you do a formal presentation on a pregnant patient. So like for a new OB visit or for an admission to labor and delivery. This is exactly what we're going to expect to see in your one-liner. Okay? So this is complicated. You're going to want to go over this stuff. You're going to want to practice this stuff in the mirror at night. You're going to practice your G's and P's. You're going to want to practice your pregnancy dating. You're going to put it all together for this awesome OB one-liner right here. Okay, moving on from the OB one-liner and the HPI, I really want to emphasize the OB review of systems. There are 4 things that you should ask a pregnant patient every time you run into her, whether it's for a labor triage visit, or if she's got an asthma attack or stubbed her toe. Basically, as the obstetrician consultant, we need to care about the pregnancy. And so if it's non-pregnancy related, we're still going to ask these review systems. Is the baby moving? Are you having any vaginal bleeding? Are you leaking any fluid per the vagina? Are you having any contractions or pelvic pain? Okay? So in the first trimester, we don't expect fetal movement, but vaginal bleeding can occur. Leakage of fluid we usually describe as vaginal discharge at that point because there's not much amniotic fluid. You don't really break your water in the first trimester. And then the contractions can be pelvic pain. So you can kind of tailor that a little bit for the first trimester. But really, if somebody's pregnant, these are the review systems you want to ask every single time and present them every single time. In terms of the order of presentation, we're like everybody else in terms of the other specialties. We want the chief complaint, followed by the history of present illness, followed by the review of systems. But I really want to emphasize that the next thing that we want to hear is the OB history, the previous obstetrical history. And what's going to be really important is that you do this G by G by G. So if you got a patient who, again, is a G3P1011, you want to give us all these details. So in G1 in 2018, she had a normal spontaneous vaginal delivery of a baby boy who weighed 7 pounds 2 ounces with no complications. G2 is in 2019. She had a spontaneous abortion at 8 weeks. She had a D&C with no complications. And G3 is her current pregnancy. If a patient has 10 pregnancies, yep, we want you to go and get the history of all of them and present them to us for a new OB, for a labor admission. Some patients will have so many pregnancies that they don't know all the details. You can kind of group those together, but you just need to figure out the basics: vaginal delivery, C-section, abortion, and about how far along. And then if it was a live-born baby, sex of the baby, weight is always very good. Any complications, that's going to be really important. So do OB history first, well before medical history, well before surgical history, I promise. After OB comes GYN. If this is a non-pregnant patient, you can switch these, you can flip these and do GYN first, then OB, but do these 2 first. When we talk about the GYN history, this could mean a whole bunch of different things. At the very basics, we want you to be asking if they have a history of sexually transmitted infections and if they have any abnormal pap smears in their history. If you want to be really fancy, you can throw in the menstrual triad. That will look something like this: 11, 28, 5 to 6. And what that translates to is that her menarche was at age 11, her period cycle is every 28 days, and her periods last for 5 to 6 days. All right, so you'll see that menstrual triad in our notes sometimes. That will wow people. So there you go, a little bit of boost. And then after you do the OB history, then the GYN history, then you can do all these other histories: previous surgical history, previous medical history, meds, allergies, social, family history. Please do it in this order. Even if somebody has a very exciting medical condition or has crazy surgery in the past, you are talking to OBGYN consultants, especially if the patient is pregnant. We want to know her OBGYN history more than this other stuff. We want to know this other stuff, but we prioritize the OBGYN history. So please put those first. All right, very fortunately, the GYN one-liner is way shorter, okay? The GYN one-liner is something like this. The patient is a 26-year-old G2P2, and so that's the shorthand. You can shrink that down, or you can do the full version. She's a 26-year-old G2P2002. Her G's and her P's add up, and I know she's not pregnant. Then, for patients who've had abortions, you can do this little fancy one right here. So let's say she's had one term birth and one abortion. You can say that she's a G2P1A1. Okay, that's totally fine. I know she's had one baby, and she's had one abortion of some kind. What's really important is to not do G2P1. All right, if you just say G2P1, I won't know if she's pregnant or not. I won't know if she's a G2P1001 and therefore pregnant, or if she's a G2P1011 and therefore she's not pregnant. So don't just do G2P1. What's better is after that, you can either do G2P1A1 or really the preferred, the longhand, G2P1011. So what would follow this would be a 26-year-old G2P2002 with a last menstrual period of. And so the one thing really to emphasize on this rotation is you must always, always, always ask the patient her last menstrual period. That is what you do on this rotation. That is what OBGYNs do. I get called to the ER sometimes just to figure out when was the patient's last menstrual period. Alright, so get in the habit of always asking your patients, if they're new. If they're new for an annual exam, if they're new for an OB visit, if they're presenting with a gynecologic complaint to the ER, always get the last menstrual period. And the reason being, let's just say, for example, a 16-year-old null-gravid patient, never pregnant, not pregnant, presents to the ER with pelvic pain. Well, I need to know where she is in her menstrual cycle. If she's early in the menstrual cycle, she could have a follicular cyst. If she's in the later half of the menstrual cycle, then this could be a hemorrhagic corpus luteum. So knowing when her last menstrual period was is very helpful. A 32-year-old with a last menstrual period of 4 months ago and a negative urine pregnancy test, the reason she's coming to my office, the reason I'm getting called to the ER is because she hasn't had a period for 4 months. Okay? And so even if that's not why they're calling me, whatever they're calling me about, the fact that she hasn't had her period in the past 4 months is probably related to her issue. And so getting her last menstrual period is really helpful. And last but not least, if somebody is menopausal, you can say they're menopausal, but we also like to know how long. How long have they been in the menopause? So a 64-year-old with an LMP of 11 years ago, lets me know that she had her menopause at age 53. That's pretty much average, and so that I would know she had an average age of menopause. So when you're doing your GYN presentations, age, G's and P's, that should add up, and then with the last menstrual period of the date. Okay? Always do that. Alright, and that's pretty much it for this talk. I do want to point out here that in Husky CT, if you go under our orientation tab and look at the orientation and introduction materials, if you kind of scroll down, you'll see sample notes. Right here, sample OBGYN charting notes 1. If you download that, that has all of these note templates for you. It's got the H&P, kind of I described with chief complaint, HPI, the OB One Liner, the OB review of systems, the order that we like to present these things in, including our physical exam after that. It's got operative notes. It's got postpartum vaginal delivery and postpartum C-section, day 1 through day 4 notes. It's got GYN notes and clinic notes. And so download that. You can paste that into Epic as your note templates, or you can just use it to write your notes. It is a great resource for you there in Husky CT. Okay, so hopefully you're going to be doing outstanding OB and GYN presentations. Get in the habit of learning the OB and GYN one-liners, understand G's and P's, and how to date a pregnancy. If you can do all that starting on day 1, you are going to be rocking it out. Okay, welcome to OBGYN, and we'll see you soon. Take care. Bye-bye.